Thank you, Abraham, for the excellent presentation today. I'd like to say that Abraham definitely won the Prosectus Prize in secondary anatomy. There's no question about it. My topic today is smile design, contemporary diagnosis and treatment planning. And I think smile design has been talked about so many times in everyday dentistry. You open up the YouTube, you just have so many people talking about smile design. But what I'd like to talk about is trying to make the clinicians think about smile design, how the facial expressions but dynamic, not static format. So what I find is everybody wants a recipe. And people want a recipe because it fits the bill, fits the thinking, how we do things, how we create things. And I took this photo because my wife's favorite cookbook, and I placed it in the oven and I burnt it. And she was very upset about that. And she was upset because I want to prove my point. Well, the problem is that aesthetic dentistry is limited by imagination, self-imagination, not by a digital workflow. We tend to be too much stuck up on digital concepts. And I'd like to probably today change your paradigm in how to think, how to assess things. I mean, half an hour is not enough time, but the cookbook approach to aesthetic dentistry just really belongs in the kitchen, you know. There's no such thing as recipe. We have to think about how we do things. The golden rule is that there's no index to measure, golden index to measure aesthetics. There's a lot of research being done. I'll talk a little bit what Derek talked about. So in many ways, we need to think about how do we do this? Okay, naturally, there are certain guidelines, you know, so 2 axioms and 10 commandments. I won't be able to cover them all, but I'll cover some of it, hopefully. And when we look at the axiom 1, the most important thing is to establish confidence and trust with your patients. The patients trust you to do the right thing by them. And, you know, you need to know your patients, what their needs are. In many ways, I find that, you know, when you take the patient's photos and stick an iPad and play with your digital manipulations on your smile, that doesn't mean much to the patient, especially patients who come to you who's going to pay a lot of money to get aesthetic dentistry done. That's important. You know, who pays a lot of money for aesthetic dentistry? Well, probably 40 plus. They have the money. They want somebody who knows how to do things, and that's important. That's very important to establish that confidence and trust to the patient. But most importantly, I like what George Bernard Shaw used to say, is one of the most dangerous diseases is diagnosis. Because there's only one diagnosis, and that's many treatment plans. The question to ask yourselves when you talk about things is, can you deliver? So you all talk about other people doing diagnosis for us. For instance, DSD is done by laboratories because every dentist hasn't got time to think about it. So they diagnose your patients for you, and you carry all the responsibilities. So can you deliver? That's the question to ask yourself every day you do aesthetic dentistry. So why do I look at direct diagnostic mock-up or direct Kesslin setup? You probably know what Kesslin was. It was an orthodontist in the 40s. He used to cut up the teeth of the molar and put them together, make appliances, do all sorts of things. So aesthetics is facial driven. We know that. We need to understand that when we restore faces, it could be correct facial dimension, correct occlusal vertical dimension. We got a lot of functional MRI studies at the University of Sydney and in Germany that proves that to restore the function and aesthetics and dental facial well-being or psychosocial well-being of the patient is important to be able to create that correct facial profile. So that's really good for the patient. So, you know, patients are able to adapt to the new facial dimensions that you're trying to create. So we have a number of issues here. As you can see, we have here the laboratory, the dentist, the supplies, and the patients. And we look at that, we can apply the whole concept, how we approach dentistry. I work with an orthodontist, Derek, a lot of the times. We diagnose patients together. I'll pull this slide out of one of the lectures we normally give to the local dentist. But this is important because what I want to know is when we look at all this concept of aesthetics is who owns the problem? So we've got dental supplies who supply materials, we've got dental laboratory who makes them, we've got all these other companies who sell you as digital concepts. Who really owns the problem? Well, what I find is that we need to spend a lot of time with our patients so that patient is a respected decision maker that owns the problem. And unless we're able to explain to the patient, you own the problem. And it'll be your problem forever. So we need to establish realistic treatment goals before we start. You can't promise the world. It's better to under-promise and over-deliver. So when we look at patient assessment, We look at basically position of the face, the upper arch, especially the maxilla, as Derek mentioned. And to me, maxilla is extremely important because position of the maxilla is most of the time where the problems lie, not in the mandible. And most of the time when we work, we try to get the maxilla in the right place, in the facial dimension, anterior, posterior, and lateral coronal positions and sagittal planes naturally. So we know we tend to work on the lower part of the face. That's our job. That's what we do most of the time. And when we're trying to do aesthetics, we know that without good facial symmetry, especially position of maxilla, and resulting orthodontics or prosthodontics, it's not going to be that good. So, get the midlines right, get all those things right. Well, look at this patient. I think she's got a symmetrical face. She's very attractive, not concerned about the teeth, doesn't want orthodontic treatment. But it took a bit of time to, you can see she's got all the right proportions, all the symmetry. Normally when you see a nice symmetrical patient, I tend to sort of stop them and say, I think you've got a very nice symmetrical face. You compliment them. And again, we did diagnostic mock-up for this patient directly in the mouth. Took about half an hour to do. Didn't need any digital formulations at all. Zero, only by hand. Because the patient's there. Look at the patient, there's your reference point. Do it. You're the artist. Do it. Don't need anything else. And again, before and after, and we look at the final measurements, it sort of fits the bill. So, why do we need the diagnostic mock-up? Because it really changes people. When you start doing this sort of work and you get experience in direct diagnostic mock-up, you're looking at all the outcomes. You're looking at the endpoint position of the anterior incisors, the maxillary arch, in the facial plane. You're actually dealing with the face, not with the teeth. So as a clinician, we look at the face, understand where the teeth lie, understand where it lies in relation to the facial proportions. And you actually position maxilla where it really needs to be to improve the facial appearance. And on different angles, you can see how we change. This is diagnostic mock-up. They don't actually find restoration. It all comes off after an hour. So Derek talks about facial proportions, how we want the goal of proportion. That's very good. But Farkas did an interesting study back in 1987. And even if you know the orthodontist, you know who Prophet is. But what counts is symmetry and proportions, because beautiful faces are really just average in all dimensions. They're average. What we see beauty is what the patient sees herself. We try to complement the patient's facial aesthetics by putting the maxilla and dental proportions in the right part of the face. So what he discovered was that although we know that Da Vinci's case, third, the lower third has got an extra third. So in other words, this part of the face has got an extra third. So that makes me think what Derek said was right, because with Angelina Jolie, lower lip being more forward to the aesthetic E plane, rickety plane. So this actually is the new level of aesthetics, because it's the lower third has an extra third. That makes clear sense to me, and I sort of copied and pasted in between the lectures today to prove that point. So what happens when patients initially present? You can see we get an anterior class, skeletal class 1 anterior open bite. And, she needs all the concepts of orthodontics, orthodontic surgery, another orthodontic finishing followed by restorative care, but that's not what the patient wants. But more or less, we need to get this patient, her age, back in the marketplace. That's what we do most of the time. And to me, when we look very carefully, you can see that all the defects that are present. You probably notice a reverse smile line here as it comes up. There's a gum asymmetry. There's a midline asymmetry, all the things that you can see, I can see as well. And the patient probably can't see, but we like to see how can we help this patient. So my aim is initially to diagnose in mock-up. I'll just build what I think it should be, and using the composite that you can build a final composite. So don't use some crappy composites that you can do diagnose in mock-up. Use the composite that you normally use to restore this patient as a final end. So this is diagnosed in mock-up. This whole thing comes off. Doesn't take long to do it once you're trained. And actually that helps me to restore symmetry. Remember that smile is not static. Smile is dynamic. It's dynamic part of facial expressions. This is what we do as dentists. That's a composite mock-up. We did 10 composite veneers, some gum brick contouring, and you can see that different effects of this as we are achieving, and also this is 5 years post-op, and this is a 10-year post-op as the patient ages. Now we all forget that people do age. We forget that. We fix the teeth there and then. That's a great result. Thank you very much. See you later. But people do age. We forget. We all age. And it's important to understand that if you put the teeth and the smile in the right place, they age well. People age well. Now, here's another patient. Had orthodontic treatment done twice. Doesn't want to have a bar or braces. Will not have it. No question. So we got a problem. And to me, position of the maxilla is most important important part of the facial expression in 3D. You can, as I having talked about, you can see exactly what I'm saying. In terms of the upper anterior teeth, could be talked better with orthodontics because of excessive lateral corridors, and she's trying to hide the diastema. She's in the microdontal range. So we got cantomaxillary plane. You can do your own aesthetic analysis. There's no such thing as this particular aesthetic analysis. It doesn't matter. I can make my own. It's how you see the world. I like to sculpt, for instance. I see things differently. But, the most important thing is that those of you who haven't had a chance to do a denture setup, it's actually a denture setup. That's what we do. We get the teeth, get it plain, put your teeth where you think it should be. So when we proceed with this case, we've got a midline issue in the corrected. One of the important things that Spear talks about in 1999 is that towards the middle of the incisor should be basically 90 degrees. As you come to the end of the incisor, should be a bit higher than 90 degrees. That allows you to bring the teeth forward, torque them, create them, position them, so it just lies behind or at the vermilion border, wet dry line. That gives you good aesthetics and functions and phonetics. So having said that, when we look at our patient, for instance, you can see exactly where the anterior incisors to come forward. Now we could do Invisalign, any other treatment, but she doesn't want any form of orthodontics. That's why we went ahead in her case and did the diagnostic mock-up for this patient. That's the initial presentation. Let's look at the lateral calf, superimposition, and see the whole results. As Derek was mentioning before, the anterior incisors positioned in terms of lip support. So we went ahead and did some lip augmentation for this patient. The teeth going to disappear. And most of the patients coming in, they've done his lip augmentations and teeth disappear. As a matter of fact, it's really strange because I see my patients walking through, the new patient, first thing comes is the lips, and then comes the mammary glands, and then comes the patient. And you think sometimes, gee whiz, where are we going to? So the whole thing is wrong and needs to be reassessed in the proper format. You've got thin upper lip. So before I do any augmentation, let's just look at the assessment, look at all the different positions. I mean, teeth are interdigitated well. You can bring the lower anteriors forward and the upper anteriors forward. Had 2 orthodontics done twice. It's just not an option. So on the day of the diagnosis, this is the one thing that's really important. Look how she's dressed. She turns up for the diagnosis. She wants to look good. She wants to feel good. And it's important to complement the dentofacial aesthetics of this patient. So usual things, simple things. It has to be simple. Diagnosis has to be simple. We have to think simply. The average length of the central incisors is about 10 to 12 millimeters, right? So I pick up composite and I build up the central. That's the denture tooth setup. Okay, then I go ahead and look at the position of the incisor ledge, make a smile, look at the lip border, test of speech, function. Can she speak? Yes. If she can speak, then I'm in the right place. And we do the rest of them. So if you build up the incisor plane, it's more like a denture tooth setup. And we go next stage. And this is a diagnostic mock-up. We could improve the buccal corridors naturally here. But obviously, the way the patients look themselves, look how closely women look at the mirror. You see, when some of these other concepts, when people take a video of the patients, you can't see the mirror, you got a video. No, you can't. Women want to look at themselves that close. This is how women do. And it's important to look at the effects of the diagnostics, the dynamics of the smile. And we're trying to see how we're going to create aesthetics. I just place some composite veneers, 0 tooth intervention, just to restore the facial appearance. And at the moment, well, then I would consider later on, naturally, looking at the lip pattern, as is different angles of the smile dynamics, this is before and after, just simple composite veneer placement, single shade, doesn't have to be many shades. You don't have to complicate your life. We're talking the centrals using composites. Basically, that's what I'm doing. Now I'm in a position naturally here to be able to then go ahead and do the maxillary lip fillers and improve the overall aesthetics for this patient. This is the time when we're looking at the aesthetic effect to establish harmony between dentition and surrounding tissues. This is all important. The arch position, the arch form, the shape, and the position of the central incisor. One of the most important persons that you need to understand as a reference is Rufenacht. Now, nobody knows this guy. This guy is the godfather of aesthetic dentistry, and he's an artist himself. See, you've got to be an artist to understand aesthetics, in my opinion. You need to draw or sculpt. He came from a family of artists. You should look him up. He's one of the best guys ever lectured. Lectured here in Sydney in 2004. And again, we want to create aesthetics that fits the face. And most of you will probably say that, how do people smile? Do people smile with their teeth? Well, we might think they do, but not really. The most important thing is creating that equation of the diagnostics is that people actually smile with their eyes. They don't smile with their teeth. Charles Darwin said that back in the beginning of the last century. And important, the missing link is understand diagnostics. What about this patient? Okay, she's got severe problems. Same principles can be applied to complicated cases. I see these patients all the time referred to me by other practitioners. And you can see basically she sustained a childhood burn, lack of alveolus. They have a lot of problems. How do you treat this patient? She's got residual tongue remaining, managed to speak. There's a long story. Her case is in my website, for those of you who wish to see it, but you've got a problem. So how do we see this patient? She's hypodontia, and looking at different angles. She's straining to smile. Look at the facial muscles, the neck muscles. Okay, she's about 35 years of age, but she looks much more older at this stage in her life. Had muffled dental tryptophan. You can see it on the cone CT. We got problems. So first things first, we maintained her, did some orthodontics, positioned up the teeth in the right position, and followed by managed to do some composite work and gum leveling. We got the facial right. This is the composite veneers because we didn't want to porcelain at this stage. There's other work to go in the mouth. This is a work in progress. But when you really think about it, that these are the people who do aesthetic dentistry that put their lives in your hands. When you start to treat these complex patients, understand that use is a confidence-building exercise. Diagnosis is the key, not so simple talk. Talk is cheap. You've got to get this work done. You get this patient from A to B, make sure that you are supporting, holding the hands, not just having the light at the end of the tunnel, but having the light within to maintain the patient right through the process. So we like to change our patients and understand what we're doing for this patient, going from this to that, improving the facial profile. It's all about the face. It's not about the teeth. It's all about the face. And naturally from here to there, you can see how there's a, ease of smiling by placing the mags in the right place. We did some partial denture for the lower arch. We changes people. If we didn't just restore occlusal vertical motion of fascia, we changed the whole patient's confidence. We gave her hope. And you can see this girl is absolutely brilliant. I mean, she's a beautiful girl. Look how tall she is. She's a beautiful girl. That's what we do to our patients. Improving aesthetics is the key. So what happens, does every patient need orthodontics? Does straight mean beautiful smile? You got to think about this. Not the straight teeth doesn't mean beautiful smile, and I'll qualify that later on. But when you look at this patient, it came from an opinion, been to 3 maxillofacial surgeons, 3 orthodontists. They all want to do some, this is maxillary bioprotrusion, you can see it, and they want braces, orthodontic surgery, and you name it. And we start looking at the patient from different angles. I said to her, look, when you have your treatment done, can you ask all the specialists, when they do your dentistry, in other words, surgery and orthodontics, will it affect your upper lip, your facial profile? Will it affect your lip profile, your lip support, your lip thickness? None of them could guarantee it. They said, no, it'll change. So we thought about it, and we did diagnostic mock-up. We realized that by simply doing small gum recontouring, we can actually improve the whole ratio. She does have a symmetrical face. It's just a maxillary canter within the facial frame. And again, this is composite veneers with some recontouring. This is 2005. Now, it's important to understand how people age. How people age is the key to aesthetics, not just doing that at that point of time. So, this is 2005. Okay, this is 2015. We maintain the whole, facial profile. This is key. We maintain the beauty. Imagine if she had 4 bicuspid extractor or orthodontic. You would have lost that profile. She looked a lot older. Most of the time, parents complain that the kids look worse after orthodontic treatment because the orthodontist didn't look at the patient facially, just looked at the models. Okay, another angle. You got to look at different angles, and I like looking at all these different angles of the patients. We maintain the whole dental facial aesthetics of the patient. Looking at the right across the line, you can see this doesn't look too bad at all. Doesn't look too bad at all. Gummy smile doesn't mean terrible. It's a beautiful smile. Just maintain natural aesthetics. Time. Time is important to maintain aesthetics. Providing facial support is important. Funny enough, the lower arch crowding was not a concern for this patient. See, what we think is right for the patient is not necessarily what the patient thinks is right for them. So you have to understand the both sides of the equation. Here's a patient, 2018. What do you see? There's a slight overruption here of the premaxilla. Okay? We can go back and just do some Montgomery contouring and put some composites and keep it going for the next 15,000 kilometers. It's understanding aesthetics, but what we have? We have a beautiful face, don't we? You look at the lip contour, look at the lip thickness. She's perfect. She's perfect. All we had to do is balance the teeth, position the maxilla to obtain the, the normative dental-facial aesthetics. Really 1950. Know that facial features of a patient with correlated occlusion may not necessarily be beautiful. Because what? You get a straight model, put on the table, oh, it's perfectly straight. But you put that model on the face, it's not the same. That's why you look at the face. I never look at a patient who comes to aesthetic treatment, the teeth. It kills me in Prosthetic Academy conference at the Amsterdam. They look at the teeth. What about the face? They missed the point. In this case, I have to commend orthodontists. They're way ahead of the game than prosthodontists. They're just catching up now. So how do we look at things? Observation. You can't look at 30 degrees of the chair and do aesthetic dentistry. I mean, have you seen an artist or a sculptor go 30 degrees and sculpt the nose? Or just straight on. You got to see things straight on. You turn a patient around. You can see it straight, and that's how you treat patients. So, diagnostics. You get a facial treatment directed to facial balance. This is how I do my mock-ups, okay? You're like an artist. You got to think like an artist to be able to create good aesthetic dentistry. That's why I can't give you aesthetic index. There's no gold index. Every case is very different. So here's our patient presents sent him to our plastic surgeon. He's done all the cheeks. He's done everything else. He's realized that if he does any lip fillers, okay, it's going to get worse. It's going to look heavy. It's going to drop the face. Am I right, Abraham? So what we need here is a scaffolding. This is your job. You need to be able to get a scaffolding to improve. This is a facial curtain and buccal strap. The whole thing's sunken. What do we do? Look at the smile. She likes to improve a smile. The buccal corridors. You have to understand facial aging pattern. It just lectures a bit too long for me to be able to put all this. But important to understand. What do I do for this patient? I'll do diagnostic mock-up. You see, most of you will take the crown and bridge off, try and make a temporary, then blame your technician, it's not quite right. I wouldn't even touch this patient without doing mock-up. So I go do a direct mock-up on the crowns, I'm building the smile line, I have improved lip thickness, okay, I haven't even committed this patient. She's not happy, I can just take it off, see you later, that's fine. But I know where I am. And compare that when you look at the nasolabial fold, when I do the diagnostic mock-up, you can see the difference. Now that's the difference where dentist makes the difference. So no matter facial filler is going to make that difference unless you provide scaffolding in the face, the middle face, and lower half of the face, sorry. Again, we do diagnostic mock-up. This is, again, diagnostic mock-up. You can see how the patient looks 10 years younger. If you don't believe me, let's make this patient talk. Okay? That's the same patient. How do we do diagnostic mock-up that makes a difference? You can't do this digitally. Your real patient in real time. Okay, that makes a difference. So moving forward, what happens if a patient about 40 years of age presents in your practice? And a lot of us don't think at this stage. But what happens is that we got some issues. Okay, we have periodontal disease, non-smoker, good old hygiene means there's a higher risk for periodontal disease. So we go for the whole program, all the normal things we need to do. Okay, we get stability, and we then basically ready for this patient to go ahead. So looking at different effects, you get a tooth wear, all the things that you have, past orthodontic treatment. You can argue how good it was, how bad it was, but nevertheless patients here, they want treatment. There's a food impaction here, there's a contact problem here, there's lots of tissues there, lots of bone there. So you have to address all these issues before you start doing any cosmetic dentistry. We internally bleach this tooth, and then we're so ready. Looking at treatment plan, diagnostic mock-up. That's the first thing I do. I do my mock-up. What does it tell me? End position of the maxilla, end position of the tooth. This is tested. It tells me where I'm going to go. I tell the patient, you know what? We can do post-veneers for you, but if you do orthodontics for you, you get better result. I have the teeth and the arch in a better position. And I can do this for you. So, looking at direct mock-up, different positions. See, you can't just look at a patient facially. You got to do oblique view. Facial oblique view is really key to aesthetics and sagittal view. I want to see how this is going. I need to look at this and say, where am I going for this patient? How am I going to treat this patient? So she finally convinced that if he did orthodontics, she'd be happy. So first day, just the upper arch. Look, I'm a prosthodontist, but if it's within 6 months' time, I don't mind orthodontics. I haven't got time. I just want to get it done, get it away. So I do PAOO. I'm surgically trained prosthodontist, so to me it's not an issue. I can really move to it very quickly. And we got 3 months. Let's start. We're starting, so this is 3 months to go. Start. And we come back 3 months, and you can see I've got the teeth in the right position. I've got the gums in the right position. I've got the papilla in the right position. And we have a patient that's looking maxilla. Teeth in the right position. From here, it's very easy to treat. So you go back in, I tell my technician, this is the instructions, I give it to him, follow my instructions. If you want to do cosmetic dentistry, and I know everyone sees a cosmetic dentist, you have to be control freaks. You have to control every sequence. The technician doesn't tell me what to do. I tell the technician what to do. I tell them exactly how I want it. They get my prescription. They get my prescription. This is another patient. Harry's here. We talk. We discuss. And for instance, then we design the veneers that we want. This is a different patient. But I know that this veneer design is going to go exactly where I want in the face. Because I know the fact that when at the end of the day I'm doing aesthetic dentistry, I want things to look natural. Okay? All right. So having said that, this is diagnostic mock-up initially. We've completed orthodontic treatment. And this is the lab instruction. Minimal adjustment. I don't give local for any veneer preparations, just simply remove the edges. I do minimal prep veneers. They all have linear palatal overlaps, and naturally, 0.2 millimeter margins. Just quickly I go through this. And your thin biotype, here's your palatal retention. So this is the initial presentation of this patient. Let's look at the next stage. This is the lips and the face with the veneers, and that's the veneers in the right position. So we're improving the whole dentofacial aesthetics of the patient by putting teeth where they should be in order to improve the overall harmony and symmetry of the face. Again, you can see the face, how having a bit of an arch expansion, putting the teeth in place, you don't need fillers. There's no need for fillers here. The patient looks fantastic here, in my opinion. Again, different angle, and we have a patient that is happy to smile. So, why do we do these things? Why do we do diagnostic mock-up? It's because it allows me to assess the patient in dynamic format, in real-time format. I don't need any more digital manipulation, which is what it is what it is. So, diagnostic direct testing setup. Always. You got to look at the patient. One of the most important things about doing diagnostic mock-up is, for instance, when you have a patient, I'm doing a mock-up here, you can take the face, I'm directly on the patient, I can take the face different directions, and assess and you can never do direct mock-up just sitting down. You have to stand up and obtain the aesthetics that you need to do for your patients. Well, having said that, direct diagnostic composites should be considered as the gold standard in today's aesthetic dentistry. You don't have recipes. You create a prototype on every patient, because every patient is a prototype. Thank you.